Hi, this is Andrea Kane, and I'm here with HIT 340 Comparative Records. It is now week 7, and we are starting to talk about Chapter 8, which is substance abuse. Sorry about that. We are on course objectives 8.2, which include unit objectives 9.2.1 through 9.2.6 on the topic of substance abuse. Our learning objectives, at least from the book's perspective, are to describe the various settings and caregivers that are commonly associated with substance abuse treatment, look at the impact of state and federal laws and regs on the treatment of substance abuse clients, talk about those who accredit substance abuse treatment centers like CARF and Joint Commission, talk about a typical substance abuse client record, inpatient and outpatient settings both. Talk about the current reimbursement issues that are related to substance abuse treatment, compare DSM and current version of ICD-10 as they relate to the coding of substance abuse client records, discuss quality improvement, utilization management, talk about the role of the health information manager, use of electronic health system technology, health records, and managing substance abuse client information, and identify any specific legal or ethical considerations associated with the confidentiality of substance abuse client records. So, some settings for substance abuse care: outpatient, intensive outpatient, residential inpatient, medically managed intensive inpatient, substance abuse education and prevention programs, self-help recovery groups, and aftercare. There are the medically managed intensive inpatient is basically a detox unit. That's where someone comes in and there is a physician and other providers that are monitoring the patient and helping them medically detox off of whatever chemical addiction they have. So what are some categories? There is abuse and there is dependence. Those are the two basic diagnostic categories. Is someone just abusing the substance, or are they dependent or addicted to it? So some terminology. You have alcohol and other drug dependence, psychoactive substance dependence, drug addiction, alcoholism, or chemical dependency. And and those who utilize these services prefer to be called clients or individuals receiving services. In the 1950s, there was some residential treatment and Alcoholics Anonymous, if you've ever heard of AA. And now most treatment is outpatient. The only thing that's usually inpatient is an intensive detox program or a inpatient residential program where they're using behavioral health or mental health services, as well as substance abuse treatment. Outpatient treatment has regularly scheduled sessions. It's usually individual therapy. It may be done at a mental health center, a hospital-based outpatient center, a freestanding treatment center. It lasts up to a year or more. Then you have intensive outpatient, or what's called partial hospitalization. And that's where you have a minimum of 9 hours per week within a structured program. And again, these are outpatient. So whether it's intensive outpatient or partial hospitalization, you want to think of these are outpatient settings. They're just more compact and truly more intensive than the others. The others are usually once a week. These are once or twice a week. These are every day. And then these programs sometimes allow someone to go to work or school while they're going through it. Partial hospitalization is usually a daytime treatment. It's usually someone comes in at 8 in the morning and they leave at 5 in the afternoon, and all day long they are receiving treatment. And these intensive outpatient or partial hospitalizations are used both with mental illness settings for behavioral health care, as well as substance abuse chemical dependency treatment programs. There's a residential inpatient treatment program. These are for people who have subacute or minimal medical, behavioral, or emotional problems. Typically, they lack social supports. They can be a halfway house or quarter-way house or that type of thing. Then you have medically managed intensive inpatient treatment. These are clients with acute programs, or I'm sorry, acute problems, not programs, acute problems that require a full range of medical and support services. These are acute general hospitals, acute psychiatric hospitals or units, and specialty hospitals. These are typically where you're having actual detoxing taking place. These are patients that have a multitude of problems. They probably have something at least behavioral or emotional along with their chemical dependence. They may also need medical assistance as well. Going back to the residential inpatient treatment, there are facilities that are private that have inpatient treatment where someone will go and stay for 30, 60, 90 days for not only their detox, but also they get behavioral health services, including counseling. They may have other treatments available, but it's really focused on getting them off of their addiction and being able to establish life skills in the hopes that they will not relapse after they leave. Other settings, there's educational programs, early intervention for at-risk persons, and then there's self-help recovery groups. You may have heard of Alcoholics Anonymous or AA. That is really the prototype that these are based off of, these 12-step programs, trying to utilize groups and personal accountability as well as group accountability to stay on track. These support groups often use a form of cognitive behavioral therapy as they go through to try and work through their issues and to stay on track. Types of clients, they're generally from all ages and socioeconomic backgrounds. It can include teenagers. People can be referred to these programs through their employer's Employee Assistance Program or EAP. They can be dually diagnosed with both a mental illness as well as a substance or a chemical dependency. They can also be court referred for care or treatment. Types of caregivers that are involved with this definitely include physicians, PAs and NPs, nurses, counselors, case managers, recreational therapists. Typically, these are not patients that need aids, although you may see aids in a hospital-based medical detox unit, but typically in the residential and more outpatient settings, you don't see the aids. Regulatory issues, Joint Commission and CARF do surveys. Medicaid has its own requirements, and sometimes the state Department of Health will come in and survey on behalf of Medicaid. They have lots of documentation, legal administrative documentation that has non-clinical information and required legal documentation, as well as clinical assessments and an individualized treatment plan. There are, even though it's not really reflected in these slides, in reality, it's very, very similar what's happening in a inpatient behavioral health unit and an inpatient chemical dependency detox unit. And the same types of information are often gathered and required. And you often see where maybe you have a patient who starts out in the inpatient psychiatric unit, and then once they're stabilized, they go for the chemical dependency part of their treatment, or vice versa. You often see someone come in for inpatient detox. They go through detox for 2, 3, 4, 5 days, and then they identify that they've got some issues and they need to be over in the inpatient psychiatric unit, and so that transfer happens. So there's, when it comes to these patients, both mental illness as well as chemical dependency, there's a lot of non-clinical and legal documentation that's required to make sure that people are there for the right reasons and that they are being treated for the right things, and then they have to be clinically assessed and have a treatment plan. Some key documents in a substance abuse record include that clinical assessment that has to be completed before they develop the treatment plan, and then they need an individual treatment plan that's based on that clinical assessment. Reimbursement and funding. Most often, it's the client who pays. I had some friends who had a daughter in her early 20s who was chemically addicted, and once she was stable, within a day or two of coming into an ED for treatment, she was stabilized, and then she was transferred to a private inpatient residential facility that she stayed at for 3 months. And the facility charged $30,000 a month in client fees. So it's very expensive, extremely expensive. Private insurance sometimes pays part of it. For these non-private residential treatments, some will take Medicaid or Medicare. There are some government grants and contracts. But again, this is an area of healthcare that is significantly underfunded compared to what the need is out in the public. Information management, there's a lot of flow of information. Intake, assessment, the treatment plan development, care documentation, discharge summary documentation, a continuing care plan, and then aftercare. So you have all of those. Coding classification, yes, they use DSM-5. And of course, then they have to use ICD-10-CM for all their diagnoses when it comes to billing, if you're talking about Medicare, Medicaid, and private insurance, and those types of things. There's a multi-actual format, and I wish that they would have shown this to you last week when we were on the mental health chapter, because these are the 5 axes, and you can see how these would be appropriate to behavioral health or mental illness. Axis 1 are any clinical disorders that they have. Axis 2 are personality disorders or intellectual disability. Axis 3 is general medical conditions. If they have something with their physical health, like asthma or congestive heart failure or high blood pressure, those types of things. Axis 4 is psychosocial and environmental problems. This might be where you see that they are struggling with homelessness, or maybe they are involved with the justice system. Axis 5 is global assessment of their functioning. So just what they sound like. And this was all developed by the American Psychiatric Association. That's who did DSM-5. Data sets. So again, this is to substantiate the need for federal block grant money, and also to gather information so that the government and states can start seeing trends and identify needs and be able to allocate funds to address some of these issues. And SAMHSA again is involved. Electronic information systems vary greatly from facility to facility. As you would expect, those that are part of a hospital are probably using the hospital's EHR system in most cases. Those that are not may or may not be able to afford an EHR system, or they may choose to remain on paper for a while, thinking it's a more secure type of documentation system. Public community treatment programs are trying to develop standardized electronic records. And electronic records do improve efficiency in the intake process for clients and throughout the course of treatment. And a big reason why I think EHRs need to be in this setting, as well as the mental health setting, is because if these patients come to the ED, those caregivers that are providing urgent emergent treatment for them to stabilize them and figure out what is the next appropriate level of care have no information on these patients. So that is another reason for developing these a community standardized electronic record, as well as making sure that if it's a part of an organization that it's available to the local emergency department. Quality assessment and improvement. Activities vary based on the level of service and the accreditation. The Center for Substance Abuse Treatment has developed consensus-based, evidence-based treatment guidelines. SAMHSA has a database of evidence-based interventions. And then, of course, there's those NOMs, National Outcome Measures, that they're looking at to try and improve outcomes for these patients. In terms of utilization management, it's really no different than behavioral health or mental health. They're trying to treat the patient at the least intensive level that meets the treatment objectives, to utilize the services appropriately so that those who are most acutely ill with mental health or substance abuse issues are treated in the most intensive settings, because there are so many limits on those beds in those settings. And then you have criteria for the levels, addiction severity index that results in a score that can be used for research study outcomes. Confidentiality and release of information. Again, this is almost identical to what it should have been in the mental health chapter. And that is that clients want to avoid stigma. There is still a huge, tremendous stigma in our culture, in our country, regarding mental illness and chemical dependency or substance abuse, substance addiction. Clients can also fear law enforcement investigation if it's an illegal drug use or illegal drug activity. There are some circumstances that do permit disclosure. Authorizations have to be very specific when it comes to mental illness and substance chemical dependency records. That has to be very clearly laid out in the authorization that the patient is authorizing release of those things. And then you definitely need a signed business associates agreement to anything that you do healthcare related, whether it's mental illness or chemical dependency. There are some times when court-ordered treatment for DUI and other crimes, and those situations, you're balancing between the court and their rights, as well as the individual person's rights. And so you have some sticky wickets there, and make sure you get risk management involved if you have any questions. In some states, involuntary commitments can be ordered if the individual is deemed to be a danger to self or others. And that is the case. If someone is chemically dependent upon a substance that is causing them to be psychotic in behavior and they're threatening to be homicidal or suicidal, the family can pursue involuntary commitment, or the ED on behalf of the community can seek an involuntary commitment. So the emergency department for the hospital will hold the patient will get assessed, and then the behavioral health unit in the hospital are the ones that seek that involuntary commitment. So that is also possible if the family, person's family, is not involved. So what is the role of the health information manager? Obviously, there's a need for timely and reliable information, documentation to provide that proof for payers of quality and cost. It does involve traditional record management, risk management, utilization management, quality improvement, release of information, and client rights coordination. And I would say, I wish they would have put these two chapters together in the book and in the slides, and used more of the slides that they developed for the substance abuse chapter, because they really apply to both areas. Again, collecting and reporting data for statistical purposes, client electronic record systems, and confidentiality advocate. Those are all things that HIT, HIM professionals can do. for patients of mental illness and or substance abuse. Trends, specialized program, government funding and requirements, need for data, managed care. Managed care is heavily getting involved into behavioral health and substance abuse treatments because they are so expensive and because there's more and more of an expectation of that being part of healthcare. Integrated delivery systems, and then health information exchanges to make sure that information is readily available. Summary, there's a variety of treatment settings, specialized programs, funding, and the role of public treatment settings still up for debate. There is a role for us in HIT. There are confidentiality twists to it all, and then there are trends in terms of finances and technology. Web activity, this talks about a couple consent forms. You can go to the Legal Action Center and all sorts of that. So that is the end of Chapter 8 on substance abuse or chemical dependency. And I'll be back next week to talk to you week 8 on Chapter 9 about the intellectually disabled. Hope you're having a great week. Hope all goes well for you. Take care, and I'll talk to you again soon. Bye.